We'll continue our discussion around drowning and water rescue by discussing the rescue portion of the presentation. For this course, rescue will be generally pretty simple. The majority of us will not have advanced training in water rescue, and that can include life-saving and swift water rescue. There are many formal courses that can train people to be advanced water rescuers. This is not meant to substitute as one. If you should come across a drowning victim or be in the presence of a drowning scenario, the first thing you want to do is to activate EMS. Next, you want to be concerned about rescuer safety. The only thing worse than one victim is two, and you need to consider the fact that the conditions that led to the drowning scenario are likely still present, such as a strong current in a stream or river, or a rip tide at an ocean beach. There's a saying that is listed here that helps people remind themselves what to do in a drowning scenario. It's reach, throw, row, go/don't go. And that last part, go/don't go, is because if you are an advanced water rescuer and have the training, you can choose to go, but people like us that lack that advanced training should not go or don't go. To break that saying down a little bit more, reach would be if you have a long object such as a pole, or at a lot of public pools they'll have the long pole with the loop at the end. You can extend that out to the victim, they can grab it and you can bring them in. Throw would be to throw something along the lines of a life preserver, a buoy, anything that could float, so that you give the victim something to hold on to keep themselves above water. Many of those life preservers will have a rope attached to it that you can then tow the patient into safety. Row would be if there's some sort of water vessel, a rowboat, canoe, that you can actually use to get out onto the water to rescue the patient. Now this has to be done very carefully because it needs to be large enough for both you and the victim, and you need to be in a scenario where you're not at risk of toppling over or losing control of the vessel and becoming a second victim. And we've already covered the last portion of the saying, go/don't go. Moving on, many of us may have heard or seen in water resuscitation on the movies, and that is essentially where someone is providing ventilation to a person who is a drowning victim still in the water. A picture of this is to the bottom right here. This can only be utilized in patients who have a pulse, but are somewhat in respiratory arrest, likely due to hypoxia or aspiration. If the patient does not have a pulse, then you need to quickly evacuate them from the water and initiate chest compressions. As you can see here in the picture, we're assuming that this patient has a pulse, they have a flotation device that can keep the patient aloft, and finally the person is delivering assisted ventilation. This also pertains to individuals who have the advanced training. Finally, we'll discuss spinal precautions with rescue, and in general, spinal injury is pretty low in most drowning incidences. It has a low prevalence, somewhere between 0.5%, although one study ranks it as high as 5%. But you have to base it on the mechanism that occurred. If the patient was diving just prior to the drowning event, assume that they have a spinal injury. However, spinal immobilization and spinal precautions are a second priority to evacuating the patient and establishing return of circulation, whether that be through assisted ventilation or through advanced cardiac life support, ACLS, with chest compressions and the like. Essentially, in a drowning scenario, we might feel like this after we've activated EMS and attempted to reach, throw, or row, because we are not going to go. So let's say that you're able to rescue a drowning victim and bring them to land. Now we're going to go through some of the tenets related to land-based advanced medical care and resuscitation of a drowning victim. Below I have listed the four main tenets that we need to consider, and that's mental status, a person's respiratory status, presence or absence of a pulse, and then their core temperature. If a drowning victim presents to land after rescue and is awake, then our main goal is to monitor their respiratory status and anticipate any changes in that. If a victim is unresponsive but is breathing spontaneously, then you assume they have a pulse and place them in the recovery position. You obviously want to check the pulse, but that won't be your main focus because one cannot generally breathe without a pulse. If a victim is unresponsive and is not having any spontaneous breathing or is apneic, the first thing you want to do is give 5 rescue breaths. Now, this varies from traditional ACLS with providing 2 rescue breaths because the main issue of drowning is always hypoxia. So, if we can attempt to reverse that, we're better off in the start. So, after you've delivered those 5 rescue breaths on an unresponsive patient who is apneic, then you should check for a pulse. If pulses are present, then your focus at that point in time will be on continuing artificial ventilation in hopes of reversing the hypoxia and preventing cardiac arrest. If you remember that continuum of drowning from mild respiratory impairment to cardiac arrest, we're trying to prevent cardiac arrest. Now, if ultimately you give the 5 rescue breaths in an unresponsive apneic patient, and then you check for a pulse and they do not have a pulse, then you are going to initiate CPR with the standard 30 compressions alternating with 2 breaths. And in the course itself, we'll cover how to place someone in the recovery position while maintaining spinal immobilization if necessary, and we'll go through this sort of algorithm once again because it can be quite confusing. While this slide is pretty busy, what it's giving you is an algorithmic approach to the evaluation and intervention of a drowning victim. As we've already mentioned, it starts with the patient's response to stimuli, whether they're awake or not awake, their ability to answer or not answer, and goes down, eventually giving you the grade of drowning, the interventions that are recommended, and then ultimately the patient's chance of survival. So feel free to pause the lecture at this point in time to gather a better sense of the evaluation, intervention, and treatment of a drowning victim. One thing that always seems to come up when we discuss CPR in any patient is when do you cease your rescue efforts? And there are some studies that support the following of when to cease efforts related to CPR in a drowning victim. It should be noted that when it says greater than 30 minutes or greater than 90 minutes of submersion time, what that means is in these studies, submersion time was defined as the time from EMS arrival. So it did not mean the time that the patient was drowning or submerged. It was time from the EMS arrival, which is where they gathered their numbers from. So the patient could be theoretically submerged for longer than 30 or 90 minutes, but this just gives you a sort of hard and fast cutoff that you can utilize to guide your cessation efforts. And finally, it's important to note that in general, when someone is submerged for more than 10 minutes, there's a high relation to mortality and prolonged or severe neurologic injury. One of the tenets that we mentioned but didn't discuss earlier is hypothermia in relation to core body temperature. Most drowning victims will have some degree of hypothermia because most bodies of water are at a lower temperature than our innate core body temperature. In the severe instances of hypothermia, there's actually a potentially neuroprotective condition that exists, and this is due to decreased metabolism and decreased oxygen consumption. That fact results in delays in cellular anoxia and ATP depletion. We often utilize hypothermia artificially in post-cardiac arrest patients in the hospital to prevent brain injury from anoxia. Now, while this is neuroprotective during the drowning event, the second a patient is rescued, it needs to be reversed, and that is to optimize cardiac function because hypothermia actually limits and inhibits the cardiac activity. In the field, we need to reverse hypothermia passively, usually by warm blankets, removing any wet, cold clothing. In the emergency department, we should reverse it actively if need be. Sometimes that can be through varying procedures such as intrathoracic or intraperitoneal warm water. Now let's move on and discuss when to evacuate a drowning victim. The next few slides only apply to patients that are awake when rescued, because all unresponsive patients by definition require immediate evacuation to advanced medical care. You can see that there's 6 points listed below that should help guide you in when to evacuate a patient, and they cover patients with depressed mental status, severe pulmonary symptoms, and hypotension. If a drowning victim that is rescued does not have any of those symptoms, then you have other options to help guide you on when a patient should be evacuated. So here's an algorithm for those patients. As you can see, if you follow from the left, if they're completely asymptomatic, have no symptoms whatsoever, you can opt to release them right away. If they have just a mild cough and you auscultate and there are clear lungs, you could also release them right away. But if they have mild symptoms of cough, shortness of breath, RALS, and maybe their GCS isn't quite below 13, you can opt for a 4 to 6 hour observation. If they remain stable during that time, you could release them back to their activity, but if they're worsening during that 4 to 6 hour period, you would opt for immediate evacuation. And when would a situation like this be helpful, or when does this algorithm come into play? Is when you're on a long backtracking trip where it might be hours or even days hike to the nearest road or evacuation point. Because evacuation is not always a simple thing. It's not a matter of just picking up a phone and evacuating somebody. Sometimes it involves a lot of resources, a lot of time, and often can put other rescuers and other people at risk of injury and harm. The following is a table that gives you an idea of the mortality rate based on certain physical examination findings you might see in the field. And notice on cardiac examination, they don't utilize blood pressure cuff to gain the blood pressure. They just give you an idea of radial pulses in relation to lack of radial pulses, because in general, if you feel a radial pulse, you can estimate that the systolic blood pressure will usually be around 90 or so, if not higher. Now let's talk about a few other considerations in relation to drowning and rescue. The first being the Heimlich maneuver. It was once thought that because of all the water that was aspirated, the Heimlich maneuver might be beneficial to help get all that water out, much like a choking victim, but it's actually been shown not to be of benefit and can actually delay more definitive treatments such as artificial ventilation or even chest compressions. The utilization of an AED is generally not recommended. Although we mentioned that cardiac ischemia and dysrhythmia can occur from hypoxia, overall it's pretty rare. Remember that the main issue of drowning is hypoxia, and we need to reverse that. If you're able to apply the AED pads without disrupting ventilatory efforts, it may be beneficial to help identify VF or VTAC. There should be a side note made here that there are animal models show that utilizing an AED in wet conditions is not contraindicated so long as that the pads are firmly attached to the patient and the rescuers are not in direct contact with the patient during defibrillation. Moving on, antibiotics have no role in post-drowning victims, steroids have no role as far as we know, and the only lab that might be of true benefit is an ABG to assess the oxygen content of the blood. As we wrap things up, let's talk briefly about the most important part of drowning, and that's prevention. So obviously, don't use alcohol around bodies of water or engaging in water activities. Don't dive in shallow or poorly visible water. Always dive with other people or swim with other people. Always swim within your own ability, and always be aware of the current and underwater obstacles. The current is usually hard to gauge just by looking at water. Situational awareness is also very important because here what it means is being aware that drowning is always a risk anytime you're around water, even if you're not engaging in a water-focused sport. Let's say you're hiking and you need to cross a river or stream. If you slip and fall in that water and there's a quick current, you can very easily become a drowning victim. So now let's do a quick summary of the things that we've talked about in the last two lectures. Drowning is a process of respiratory impairment due to submersion in a liquid medium that is a continuum. There's no dry drowning, wet drowning, or near drowning. Hypoxia is the main culprit in drowning deaths. In free diving, because of the extreme depths in relation to the lung, you can get a phenomenon known as lung squeeze. Remember the saying, reach, throw, row, don't go. Think about those cessation recommendations that we discussed, and always consider evacuation versus observation based on a person's symptoms.